Thanks for joining us today. This is Maureen Fitzgerald. I'm from the Great Lakes ATTC. Welcome to our webinar, Stimulant Use Disorder Webinar Part 2. Today our topic is Provider Perspectives on Effective Strategies for Treating People with Stimulant Use Disorders. We have 3 presenters today. Michelle Peavy, PhD from Evergreen Treatment Centers in Seattle, Dominick DePhilippis, PhD from the Veterans Administration, and Regina Fox, BS, CSAC from North Lakes Community Clinic in Ashland, Wisconsin. A couple of notes about the Great Lakes ATTC and the Northwest ATTC. We're funded by the Substance Abuse and Mental Health Services Administration. And this year, we're celebrating 25 years of service to the behavioral health workforce. The Great Lakes ATTC serves the states in the upper Midwest, Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. Our colleagues at the Northwest ATTC serve the states of Alaska, Idaho, Oregon, and Washington. Some housekeeping notes for you all today. This webinar will be recorded. The recording and PowerPoint slides will be available on the Great Lakes ATTC and Northwest ATTC websites, and you see our addresses right there. There will not be CEUs for participating in this webinar. Our audio is being broadcast through your computer speakers, so please make sure that they're turned on and up. There's no call-in number available. Because we have 3 presenters and we're going to pack their material into 1 hour, we won't have a Q&A session at the end of the webinar. But we'd like you to post your questions in the chat box. We'll forward them to the presenters to respond to, and we'll be providing an FAQ sheet on our websites at a later date. So today's presenter, our first presenter, is Dr. Michelle Peavy. She's a licensed clinical psychologist with specialized certifications in the treatment of substance use disorders. Her experience working directly with individuals struggling with SUDs dates back to 1999. Since then, she's amassed a number of clinical training opportunities as well as research, supervisory, and administrative experiences that have broadened her knowledge base and expertise in the treatment of substance use disorders. For the past 7 years, she's been affiliated with Evergreen Treatment Services, an opioid treatment program where she currently serves as a research consultant. In addition to her work at ETS, Dr. Peavy works in the community as a private practitioner, trainer, and consultant, focusing on substance use disorders. Dr. Peavy obtained doctoral training at the University of Montana. Her postdoctoral training included a fellowship at the Center of Excellence in Substance Abuse Treatment and Education, CSAC, at the VA Puget Sound Healthcare System, as well as a research scholar position with NIDA's Clinical Trials Network. Dr. Peavy, are you ready to start your presentation?
Absolutely. Thanks so much. Let's see. So thank you for that introduction, and thank you so much, all of you out there, for your interest in treating stimulant use disorders and opioid use disorders. So as mentioned, I am associated with an opioid treatment program, and I've been associated with this OTP for a good chunk of my professional life. So you may wonder whatever I would have to say about stimulant use, since my experience is really focused on people with a primary opioid use disorder. But what I'm about to say is probably no surprise to many of you out there. And that is that people who use drugs tend to use drugs. So people who use heroin may also use something like cocaine, and people enrolled in opioid treatment, while they may be treated for opioids, may very well have things like methamphetamine or other substances, say, in their urine screens. So this infographic, I found this on the CDC's website, and it outlines this very maxim. Specifically, when people use one category of substances like heroin, they're much more likely to use another type of substance as well. So requirements for admission at a treatment program like ETS is that someone has an opioid use disorder. But we, like many of you all out there, facilities across the country, we are seeing certainly an increase in stimulant use and stimulant use disorders in our setting. And in particular, a real increase in methamphetamine use among our patients. So just as an example, at ETS, we saw a 50% increase at our Seattle site in methamphetamine that was present in UA tox screens, and that's over the course of four years, so a real increase. Okay, so, and just by the way, I'll be using the term opioid treatment, and I'm located in an opioid treatment program, or OTP, and that's of course a highly regulated environment where people are dispensed medications like methadone or buprenorphine. But people can be getting opioid treatment elsewhere in other settings and medication elsewhere. So I'll just say opioid treatment to kind of be parsimonious. So a few sort of clinical considerations in thinking about stimulant use in opioid treatment settings. So the really great news about opioid use disorder is that we have these great medications that target the disorder, and many, many people reduce or even cease their opioid use with these medications. And what we hear from patients, especially those who have been in treatment for some period of time, is that they may miss, quote, getting high, or they may miss parts of their drug-using lifestyle. And so, opioid use itself may be stabilized, and then, patients may kind of get bored, so to speak, and we hear that from our patients. So enter stimulants. So again, sometimes what we see is people come into treatment, they stabilize their opioid use, and they may actually go on to develop a problem with stimulants once initiating treatment. So OTPs, for example, are designed to treat large volumes of individuals with an opioid use disorder. And something happens when you gather large volumes of people together. And what you see is that there are so-called bad actors among large groups of people. And there may be bad actors out there that want to, for example, sell drugs to other patients. And there may be other bad actors in the environment that aren't enrolled in treatment, but they know where to access large groups of people with substance use disorders, and namely large treatment programs. So we hate this, we hate knowing this, and we hate hearing it, and it does make my heart hurt a bit. We do hear from a small proportion of patients that they may actually be exposed to stimulants while in treatment, just as a part of pieces of the treatment environment. So we hope this doesn't happen, but we know that it sometimes does. Just another sort of clinical consideration, and I know you're all hearing this too, but just of high availability of stimulants out there. And these drugs are now really in the mix of other drugs. And finally, this may seem obvious, but I feel like it's worth stating. I want to kind of remind everybody that in the context of opioid treatment, we're working with people who have a substance use disorder. So these individuals have well-established reasons for using. They have well-worn pathways of use, and probably a lot of contingencies in their environment that support substance use. So it can kind of be reasonably expected that those who use opioids are also using other substances. So hearkening back a little bit to that first slide, but just kind of making the obvious there. So what that all means is that opioid treatment settings, they are filled with people who use stimulants. And hopefully this doesn't sound completely hopeless, because I am actually an eternal optimist. And for very many reasons, I feel fortunate to work at an opioid treatment program like ETS. And one of the reasons I feel so fortunate is that we can kind of hold people close. And we can hold them close for a long, even indefinite period of time. And we can work with these individuals on all types of substance use disorder issues. So stimulant users are in opioid treatment settings, and they are in treatment. So what a great opportunity for us to seize this environment and work with them on their stimulant use. Okay, I'm going to kind of talk about 3 ways we can engage stimulant users in the context of opioid treatment. And this first point is that we really need to keep talking with people about drug poisonings. So what we know is that there's been an increase in the number of drug poisonings in which both opioids and stimulants are present and sort of implicated. So this is really demonstrated on these 2 graphs on the right, one of which is from my home county of King County, and the other is national CDC data, which I found on NIDA's website. So essentially what we're seeing here is that there is an increase in these opioid poisoning deaths where both opioids and stimulants are present. And so what we know is that mixing opioids and stimulants is not like mixing opioids and other CNS depressants like alcohol or benzodiazepine. So we know the physiological risk of mixing opioids and other CNS depressants, namely that people stop breathing. But there seems to be this other risk associated with the mixing of stimulants and opioids. We don't quite know all that goes on here, but from these data we see that there is a risk there. So to me, this means we need to continue this conversation with our patients, and it really feels like this is a wonderful time to employ our best motivational interviewing skills. So in terms of having these conversations with our patients, my advice to you would be first to simply ask about whether or not they've had one of these drug poisoning experiences in their past. And this serves a couple of purposes. So one is that we know that one risk factor for overdose death is if people have had a previous overdose or drug poisoning in their lifetime. So when we ask someone whether or not they've had a previous drug poisoning, we're getting that information about their sort of overall risk picture. The other reason to ask about this is that in my clinical experience, what I found is that asking about previous drug poisonings is a real sort of fertile ground for further discussion on this point. So I find this to be a really clinically useful question. So we're doing some assessment around risks. We're asking about previous drug poisonings. And we may want to provide some psychoeducation about overdose risks. And doing so in an MI-consistent fashion, we're asking permission. So it may sound something like this. I know a thing or two about overdose risks, and I'm just wondering, is this something that you'd like to hear about? Hey, would you like to hear a few things that I've learned along the way? And most people might say, sure, yes, I'd like to know kind of what you've got to say. And then you might even summarize some of the data that we're looking at here. So you might say something like, one of the things we've learned is that when people are using stimulants with opioids, they actually may be at higher risk for overdose death than if people are just using these substances on their own. So essentially, you're spelling out the risk of mixing these two together. And you're doing so in an MI-consistent way, asking permission. And we're continuing this conversation around drug poisoning risks. Let's see. So, and then again, in sort of an MI-consistent way, we might be engaging in risk reduction planning. And this will really depend on sort of like where that person is. So do we need to inch more towards harm, quote, harm reduction? Might people change their route of administration or think about not using alone, carrying naloxone? Or, might it be more towards reduction in substance use, et cetera? So you're already having these discussions around drug poisonings and overdose. And I just want to highlight, we need to continue that conversation when we're talking about opioid use plus stimulant use. All right, so we have, I'm wondering why there are some items on this slide that it appears that they're not showing up. This is my slide on contingency management. And we have a whole other speaker that will talk about contingency management. I'm so excited to hear what they have to say. And so I just want, from my perspective within opioid treatment, what I want to say is that we have an opportunity to leverage an evidence-based treatment to target stimulant use in the context of opioid treatment. And what this means is that we can sort of layer it on top of treatment that we're already providing. And we can target stimulant use as that target behavior within opioid treatment. And I also want to say, there's one more sort of point on my slide that I don't know where it is, but it pretty much said that what we know from research is that we can successfully implement CM in OTP settings. And I know this from my very own experience. So the director of our ATTC, the Northwest ATTC, Dr. Brian Hartzler, he partnered with us at ETS to conduct a contingency management implementation trial. And the results were really positive. It basically said that in OTP settings, CM can successfully and with fidelity be implemented into these settings. So we should do that. We should do that, and we should target stimulant use, layering this evidence-based practice on top of the treatment that we're already providing. And what we learned from this trial was that the successful implementation of contingency management really follows along the lines of other implementation literature. So things you want to do, you want to get some good champions on the ground in your agency. You want to get people excited about the idea, do some good training around it, and you also got to convince upper management that it's a good idea as well. So contingency management targeting stimulant use is a good idea, and we can do that in the context of opioid treatment. Okay, so this last idea is something I feel pretty strongly about, and here's what I'm talking about. So lots of people present to opioid treatment, and they may use stimulants. And what I'm here to say is that we should not kick people out of opioid treatment because they are using stimulants. So this is a kind of a complicated issue, and it requires a much lengthier discussion beyond the time that I have today. Those of you out there, you may have a lot of questions about how do you manage the treatment environment and how do you ensure that one person's ongoing stimulant use does not affect another person who is solid in their recovery. So we don't have time to parse all that out. However, I'll just say that it's my firm belief that we maintain people in treatment even despite month after month of cocaine or methamphetamine positive UA results. Let's see. So essentially what I'm saying here is we want to encourage people to not shut the door on people with ongoing use. And like I mentioned before, on the contrary, we have this really excellent opportunity to slow down, work with people at their own pace on their stimulant use. So I hear frequently people say, patients that is, this methadone, it really helps me with my opioid use disorder, and I'm having a really hard time with this cocaine problem. And the great news is that they are in treatment, and we can, we have a cadre of substance use disorder treatment counselors there to help people with that struggle. So my opinion is that it's successful simply to have people in treatment because we have that chance to reach them. So if we discharge people, we have no chance to work on their stimulant use with them. So keeping people in treatment, avoiding discharge. So it's useful for all of us to consider, what motivation do people have to change? People who are struggling with ongoing substance use have many reasons to change, many reasons other than program-sanctioned ones. And, you know, all of us know that addiction can be accompanied by real profound pain and misery. So it's our job as clinicians to draw out those reasons of change from our patients. And doing so, as we know, will support sort of internal motivation and allow patients to have that real ownership over their recovery if their reasons to change are really drawn out from them. Okay, so one argument that I hear from my colleagues, one argument in favor of discharging people who continue to use stimulants is something like this. Without the threat of discharge, I don't have any tools to keep my patients accountable. And I say, well, you should probably get some better tools, and also that you do have a tool, and that tool is the therapeutic relationship. And I think we can better leverage that to explore change. Okay, so I'm running low on time, but I just want to sort of instill some hope. Sometimes it can be very difficult to interface with someone that has a severe opioid use disorder, and then you layer on top this really stubborn and behavior, stimulant use, and it can feel really tough and hopeless. And so what I want to encourage all of us to do is to continue to innovate, leverage those amazing counselors that you already have, and let's keep talking and keep treating. There are my take-home messages sort of summarized here, and I will hand it over to the next speaker. So thank you so much for your time.
Thank you, Dr. Peavy. Next, our next presenter is Dr. Dominick DePhilippis, who is a licensed clinical psychologist with more than 25 years of experience as a clinician, researcher, educator, predominantly in the field of addictions treatment. He earned his PhD in clinical psychology from Hahnemann University in Philadelphia. Since July 29, he's been serving as the education coordinator in the Philadelphia Center of Excellence in Substance Addiction Treatment and Education, where he's responsible for supporting implementation of measurements-based care and evidence-based treatments for veterans with substance use disorders. Currently, he's coordinating the VHA's national implementations of contingency management and serving as the senior coach for the implementation of measurement-based care in the VA's substance use disorder specialty care settings. Along with those implementation efforts, he serves on the Behavioral Health Council for the VA's Electronic Health Records Modernization Project, the coaching work group, the work group revising the VHA National SUD Care Policy, and the Best SUD Care Anywhere training work group. He also serves as a trainer in the VHA's National Motivational Interviewing and CBT SUD training programs. He has an appointment as a clinical associate in psychiatry in the Perelman School of Medicine at the University of Pennsylvania. He's been a member of the Motivational Interviewing Network of Trainers since October 2010. Dr. DePhilippis.
Thank you so much, Maureen. Appreciate it. And good afternoon, everyone. I first want to thank you, Veronica Lang, and Dr. Todd Molfenter for inviting me to discuss, of course, one of my favorite topics, the implementation of contingency management in the treatment of substance use disorders. I also want to applaud Dr. Peavy for an outstanding presentation that touches on some of the points that I'm going to reiterate here. I couldn't agree more with Dr. Peavy's ideas, and hope to add to those. And it's great to see Dr. Peavy is actually a colleague, or was a colleague at the Seattle CSAC, which is our sister organization in the VA. So without further ado, get to our slides here on contingency management. And what I'll be talking about is the lessons that we learned in VA from our national implementation that the organization within VA for which I work, the CSAC, is responsible. Before I begin, I certainly want to dedicate this presentation to the enduring memory of a giant in the field of behavioral science, certainly in contingency management. The late, great Dr. Nancy Peavy, who developed the ideas, researched them extensively, and in the honor of whose memory, we in VA continue to make CM available to veterans. So in Nancy Peavy's honor, we continue. So I didn't want to assume that anyone had a very extensive understanding of contingency management, so I wanted to briefly give you the definition and rationale. CM is an evidence-based treatment that promotes healthy behavior by way of that tried and true principle that we all remember from Psychology 101, positive reinforcement, the law of effect, the idea that if you want a behavior to increase in frequency and likelihood, you want to reinforce it. However, just rewarding a behavior is not enough. You also need to consider the manner with which you reinforce the behavior. That is, the amount of reinforcement you deliver, the timing of that reinforcement following the behavior, and how exclusive or contingent that particular reward or reinforcement is for that particular behavior. Because let's face it, if we as human beings can get the rewards we're seeking for less demanding behaviors, we'll pursue the less demanding than the more demanding behaviors. Now, of course, conversely, delayed rewards, smaller rewards, and non-contingent rewards are not going to be as effective for promoting the learning, that is, the development and persistence of abstinence. Well, that's the rationale. Let's get into the mechanics of it. Our first challenge when we're implementing CM or delivering it more specifically to a patient is we have to decide what behavior we're going to be reinforcing. And that behavior should be defined specifically and objectively so that there's absolutely no ambiguity, no equivocation between the patient or ourselves that whether the behavior occurred or not. Thankfully, with CM, abstinence is a highly applicable behavior because we have a very effective way of determining objectively whether or not abstinence occurred, and that's with urine toxicology testing. And in fact, that is the means by which we verify abstinence. So we measure that target behavior abstinence by way of urine toxicology testing, and we do so frequently enough so that we can reinforce that behavior as it occurs. Now, when we provide that reinforcement, that provision of the reinforcement has to be immediate. The faster, the better. We don't want delays because delays weaken the learning. We also want the reinforcement to be broadly desirable and applicable to the widest array of patients possible so that we know that patients will work for that behavior. They'll assume, to use the behavioral terminology, the response cost, the demand on themselves to execute that behavior because the reinforcement is, in their perspective, worth pursuing. But we don't want to simply reinforce episodic manifestations of the behavior, periods of abstinence here and there. What we really want to reinforce is consistent performance of the behavior. And the way we do that is by escalating the size of the reward with consistent performance of the behavior. That is, with consistent abstinence manifested by consecutive negative drug screens. And we know from the research of folks like John Roll, Nancy Peavy, Stephen Higgins, that escalating the reinforcement does indeed produce continuous abstinence, and continuous abstinence itself is a very powerful predictor of resistance to relapse. But we're not going to stop there. Positive reinforcement is the most obvious element of CM, but there actually are two other learning contingencies operating simultaneously along with the positive reinforcement to strengthen abstinence and weaken substance use behaviors. That is, we also introduce extinction, that we withhold reinforcement when the behavior doesn't occur, when the patient produces a sample that is not negative for the target drug stimulants, for example, we provide no reinforcement. And extinction is the optimal way of eliminating a behavior, something we all experience in our lives. Put some coins or money into a vending machine, press the button, receive nothing. That machine has put us through extinction. We quickly abandon the behavior. But we're not going to stop at extinction and positive reinforcement. We're also going to add negative reinforcement. Now, Oftentimes, negative reinforcement is confused with punishment. They are related, but they are not the same. They're quite different. Punishment is providing an unpleasant stimulus, a shock, if you will, going back to Psych 101 experiments following a behavior. But in this case, we're obviously not going to apply that kind of aversive stimulus. Instead, the way we introduce negative reinforcement, which is, think of it as reinforcement by subtraction. In fact, you could think of positive reinforcement as reinforcement by addition. We're adding something, we're providing something pleasant. Negative reinforcement is we're strengthening the behavior by removing something unpleasant. For example, one of the most potent reasons that perpetuates drug use is the patient consuming the substance to avoid a negative emotional state, to escape from pain, to numb feelings of abandonment and so forth. Negative reinforcement is very powerful. We introduce it in CM the following way. When a patient is not abstinent, not only do they not receive any reinforcement, that's the extinction component, but in addition to that, the lack of receiving reinforcement, the extinction, we then reset the amount of reinforcement back to the original value for the next time the patient is abstinent. So now you have three learning dynamics operating simultaneously. You have the positive reinforcement, the provision of the reward when the behavior occurs, the extinction, the non-provision, the withholding of reinforcement when the behavior doesn't occur, and the resetting of the reinforcement value following use. And you might say, well, that's punishment, isn't it? Well, it's a mild punisher that allows negative reinforcement to exist because by being abstinent, the patient avoids that negative contingency. They avoid the reset. Hence, their behavior is negatively reinforced. Now, the protocol that Dr. Nancy Petrie developed really was a revolutionary protocol in CM in that it saved costs without sacrificing efficacy. In the past, CM was a prescribed and escalating reinforcement system. That is, I knew as a patient that for the first sample I produced that was negative, I was getting $5, the second in a row $8, and so forth. System worked very effectively, but it costs on average anywhere from $800 to $1,200 in reinforcement costs over a 12-week period. Now, I'm sure we'll all agree to arrest a cocaine use disorder or a methamphetamine use disorder, $1,200 is money very well spent, but good luck implementing that in publicly funded treatment programs or, frankly, in most programs, the resources just weren't there to support that. Well, for the longest time, the perspective was, well, that's an immutable dilemma in behavioral science. If we reduce magnitude of reward, we're going to get a reduced effect. And along comes a genius by the name of Nancy Petrie and says, not so fast. I think I know of a way that we can reduce costs without sacrificing efficacy. And the brilliance, the genius of Nancy's model was that the answer was hiding in plain sight. By introducing probability, she reduced costs without sacrificing efficacy. So instead of getting a defined and escalating amount of reinforcement in dollar value, the patient gets improving opportunities or chances at earning higher value rewards. So in the case of PRI-CM, her protocol, the patient makes draws of PRI slips from a fishbowl containing 500 such slips of the denominations listed on the slide. With each consecutive negative sample, the number of draws from the fishbowl increases, so there's that escalation component that produces consistent abstinence. There's also the extinction component. When abstinence is not verified, the patient makes no draws from the fishbowl. They get nothing. And then there's also the negative reinforcement. The patient avoids having his or her draws reset back to 1 by maintaining his or her abstinence. And as opposed to a $1,200 cost over 12 weeks, PRI-CM costs roughly $200 per patient in incentive cost over 12 weeks. The CM session is relatively straightforward, takes about 6 to 10 minutes to deliver. It involves the collection of the sample and its testing. Collections need not be observed, so it doesn't have to be collections of urine samples under observation. Instead, we recommend that the right to conduct observed collections be reserved by the program to be deployed randomly and with cause. that the testing regime need not include the entire spectrum of substances, only the target substance. For example, if you were targeting stimulants, we would recommend cocaine, methamphetamine, and amphetamine be the targets, such that the patient has to test negative for those three substances in order to earn reinforcement. The results of that testing absolutely must be available the same day and before the patient leaves the clinic so that we can deliver the reinforcement with immediacy. In the CM session, we'll also discuss if the patient was absent from a prior session, because their absence could affect the escalation in draw schedule. In other words, if the patient's absence at the prior session was unexcused, that is treated procedurally the same as if they had tested positive in that sample, in which case they would have received nothing and also had their draws reset. We briefly discuss any drug use or craving since the prior CM session. We use that opportunity to discuss with the patient non-targeted drug use. For example, hey, we see you're doing a good job with your stimulant abstinence. How can you apply that to your use of opioids or your use of benzodiazepine? So although non-targeted drugs have no influence on the reinforcement schedule, they are not neglected or ignored in a CM session. They're treated clinically apart from the reinforcement process. We then present the test results. If the results are negative for the target drug, the patient makes the draws from the fishbowl. We record those draw results. We disperse the reinforcement. All the prize slips that were drawn are returned to the bowl, so it's the same amount of prize slips, the same 500 every time the patient has their CM session. We then also discuss with the patient what purchases he or she wants to make with those with that reinforcement, because the reinforcement that's delivered is not cash, but it is a legal tender in the VA system known as VCS coupons, which can be used to purchase merchandise throughout the VA system. We ask the patient what they're going to buy because it's that image and that association between abstinence, earning those coupons, and then spending them on a desired prize that creates the outcome expectation that'll build their self-efficacy in abstinence. We then identify that they will better approach that desired prize, whether it be a leather jacket, an iPad, a bottle of perfume for their spouse, by maintaining their abstinence, because greater abstinence means more draws means more coupons means purchasing that prize. We then issue a prize reminder slip, which is an appointment card and more. It also reminds the patient of what they earned and what they stand to earn with continued abstinence. What concerns do we need to address in implementation? The target drug, most commonly that's going to be stimulants, because the detection window for stimulants allows for a twice-weekly testing regime. Sometimes we could target cannabis. It's a little bit more complicated given the lengthy detection window. When rapid urine ethylglucuronide testing is available, we'll be able to target alcohol presently, because breathalyzers are the principal means of verifying abstinence, and breathalyzers would need to be done daily. An outpatient application of CM targeting alcohol really isn't feasible at this time. We generally don't recommend targeting of opioids with CM, because CM is not considered an evidence-based treatment for opioid use disorder, but as Dr. Peavy pointed out, it can be used to target stimulant or cannabis use among patients being treated for opioid use disorder with MAT. We need immediate toxicology testing. The type of reward should be tangible and broadly appealing. You want to prevent what I refer to as fishbowl fraud. We don't want patients creating their own prize slips and secreting them in their palms or up their sleeves. So it's a good idea to have patients roll up their sleeves and show their palms before reaching in the bowl, making sure all the slips that were drawn from the bowl are returned to it. The testing schedule is twice a week, because again, with stimulants, their detection window being 24 to 72 hours, any of those three testing schedules, Monday, Thursday, Tuesday, Friday, or Monday, Friday, will allow us to surveil a full week's worth of behavior. CM can be platformed in any program, and the only contraindications really is that if the patient were on a medication that could produce a false positive, that could complicate the CM. That if the test results could be used punitively, that would contravene the whole purpose of CM. And if the patient has had CM already, we wouldn't want to try a repeated course without a cooling off period, lest we have the renewed availability of CM unintentionally reinforce their relapse. What does the empirical literature say on CM? Well, CM's effect which it ranges from about 0.42 to 0.58, is roughly equivalent to the effect size of neuroleptic medication on the positive symptoms of schizophrenia. Very, very good effect size for CM. In terms of VA's implementation, what we essentially did in VA is we identified a need by having the RAND Corporation identify where there was a deficit in the availability of CM in VA. VA made an affirmative allocation of resources to get the implementation started. That included funding to train personnel, to purchase supplies, for example, VCS coupons that I mentioned earlier, or the reward or point-of-care testing products. The VA tasked my organization I belong to, the CSAC, with coordinating the national implementation. And thirdly, the VA also incorporated CM implementation into its policy so that there was absolutely no ambiguity or equivocation about the endorsement VA gave to implementation of CM. In terms of coaching, vitally important element of implementation. We know that there's going to be a regression in practice of any novel clinical intervention over time. We make coaching available in an ongoing basis. Implementation sites participate in 4 calls in the first 6 months of implementation and 1 call every 6 months thereafter. The implementation sites share implementation data with us here in the CSAC. We review it to diagnose and identify any digressions from the protocol, and then we convene a call to discuss those challenges. We published the initial training and coaching regime back in 2014 in this paper by Nancy Peavy. Since then, in the published outcomes that looked at our implementation from 2011 to 2015, I want to draw your attendance to the attendance and substance use outcomes. 50% of our CM patients completed 14 or more CM sessions. That's 7 weeks of treatment in a 12-week period being completed as the median. In comparison, our colleagues in the Program Evaluation Resource Center in Palo Alto, California, found that only 42% of VA patients with an outpatient SUD treatment episode, essentially the same target population, completed more than 2 sessions. The CM effect is potent indeed. Then we look at the substance use outcome. Essentially 92% of the urine samples we collected from veterans tested negative for stimulants. We published this data last year in the Journal of Drug and Alcohol Dependence. Since then, we've been sustaining CM, and the means by which we sustain it is by constant consciousness raising. We don't want CM to fall off the radar of our VA colleagues, so we issue a monthly report that includes the latest news on CM, updates on the number of patients treated, updates on the number of implementation sites, and the urine test data. Frankly, this is an idea I borrowed from the private sector from, I'm a little guilty to admit, McDonald's. I would see these signs as we all see billions and billions served, and I realized, well, we're not quite there at billions yet in the national implementation of CM, but clearly McDonald's knows something about maintaining attention to its product. We report on the growing number of veterans benefiting from CM. We disseminate success stories to put a face to CM so that our colleagues can see and could hear stories of veterans benefiting from this success. These are some of the quotes. I would recommend contingency management to any veteran that is having a difficult time committing to a drug-free life is some of the types of quotes we receive. CM providers provide their feedback to us, and we disseminate that feedback to the field to show that, to give street credibility, if you will, to implementers, that implementers find CM a fun intervention to deliver. In terms of our implementation success to date, at this time, we've served over 4,700 veterans and 108 VA stations making CM available. We've collected over 61,000 urine samples, and more than 92% of them have tested negative for the target drug. When you look at that in terms of retention, the average retention is hanging in there at about 7 weeks, over 8 years into our implementation. Thank you so much. I'll take any questions, and I certainly want to set the stage for our next presenter. Thank you.
Thanks so much, Dr. DePhilippis. And now we're going to turn it over to our next presenter, Regina Fox. Regina is the Recovery Director for North Lakes Community Clinic in Ashland, Wisconsin. She received a bachelor's degree with a major in addiction studies from the Terrible University in 2012. She's currently working on a master's degree in mental health counseling with a focus on the forensic population. Regina has worked as a substance use disorder counselor since 2010 in several different levels of care, ranging from detox, inpatient, outpatient, medium secure prison, urban, and rural. She's also worked with clients addicted to several different substances. Regina, are you ready?
I'm ready. Hi, everyone. So let me see if there it is. So I'm presenting on the using of the matrix model to treat stimulant use disorder in the FQHC setting. The goals of the matrix, we use the matrix model here at North Lakes. The goals of the matrix model line up with our goals. So these goals that were shared, oops, let me go back here. These goals were shared when attended the matrix training in Madison this year. This helps our clientele add structure outside of their individual treatment. And that's why we decided to use the matrix model. We found that the matrix goals aligned with the North Lakes mission, vision, and values. We are a federally qualified healthcare center. The similarities is that both goals are looking at the best practice for the success of the clinician or of the clients and the patients. So if you look at your own organization's mission, vision, and values, you'll be able to recognize the similarities. The population, we use the ASAM, which is the American Society of Addiction Medicine, for all AODA assessments. We're constantly assessing these patients, clients, every time we see them, not only in groups, but as an individual. We're assessing them for all of the substances that we've talked about already today with the other presenters. What we're doing while we're doing this assessment is also talking about looking at what level of care they're needing. We're here in North Lakes, we're a level 1 treatment facility. And so we receive referrals from all sources. A few of them I've listed here. Some of the referrals come from treatment courts, probation. They like to refer to us because of the structure that the matrix model brings. We're finding that the more that we get the clients in our doors and the more that we engage with them and create that structure for the stimulant population, the more retention that we have with them and that the clients seem to be more successful. So some of the groups that we run here are, the first one is the Ready for Change. It runs 1 to 2 weeks with Monday, Wednesday, and Thursday. We did it to coincide with the other groups that we run so that when the clients get into the IOP, intense outpatient program, the matrix itself, they're recognizing they're able to continue on with this structure. So then we also, when they get done with Ready for Change and the facilitator that is running that group determines that they're ready to move on, is when they go into early recovery skills, which early recovery skills and relapse prevention coincide with each other. So like on Mondays and Thursdays, they will meet with early recovery skills and then they'll have a little break and then they'll go right into relapse prevention group. And then on Wednesdays, they'll come for family education, and then when they've completed the course for family education, they'll go into social support, which our social support I've listed there is more of an aftercare. We utilize Ready for Change. We utilize this for those that are struggling with relapses and addictive behaviors and time management. This Ready for Change, it helps us discuss the barriers to treatment because a lot of our clients have some barriers to the treatment, such as like transportation, childcare, employment. So we want to make sure that we're going to eliminate those barriers before we get them into the IOP groups. Another thing, like I stated earlier, is that the purpose of this group is to get that routine and that structure and the scheduling down. And plus this group is really good for that motivation to get them motivated to maybe make some changes or to look at some changes that are needed. Early recovery skills, a lot of those topics are about schedules. That's like lesson number 1. We talk a lot about schedules and routine. When you're actively using in stimulants, the majority of our clients no longer have a routine. They a lot of times aren't even knowing day, night. Their bodies have to get reacclimated with sleeping, actually laying down. So we talk a lot about routine, the importance of routine, the importance of those schedules, the importance of structuring your life and getting back on a routine of going to bed at the same time, getting up at the same time, taking your medications, making your appointments. That's what the lesson 1 is mainly focusing on. And then we go into triggers. We want to talk to the clients to help them recognize their triggers and help them understand that there's 2 types of the triggers, the internal and the external. This is also a group where we talk about sober meetings. We introduce sober meetings. We talk about the importance of sober meetings, how sober meetings can be a great asset to their recovery, along with the stages of recovery and relapse. And then early recovery skills with the matrix model, they focus on that thoughts, craving, feelings, and behaviors, that thought cycle, and this seems to be helpful for those individuals that really struggle with use, because a lot of them don't understand how everything connects to one another. And so this group is really good to help them understand more about their addiction and how their thoughts and the cravings and their feelings actually are connected to their behaviors. So then relapse prevention. Relapse prevention is a good tool to add next to the early recovery skills. So early recovery skills goes for 4 weeks, and then relapse prevention, like I said, is congruent with relapse prevention. What relapse prevention does then is helps recognize a relapse and the red flags that come before the relapse happens. A lot of these topics are like your coping skills, your relapse justifications, feelings. We talk about work, we talk about boredom, how to avoid a relapse drift, shame and guilt, because shame and guilt is one of those #1 factors for a relapse, and so we want to try to help the clients understand what they're going through. Some of it talks about the truthfulness, the importance of being honest and truthful, because we do urine drug screens here as well, and we let the clients know that we can't help them unless they're going to be honest with us. And so as long as they're going to be honest with us, then we can help them recognize their relapse. We can help them recognize that this relapse was happening probably a week, 2 weeks prior to the actual relapse itself. And so that's what relapse prevention we use for. Family education, that's on the Wednesdays groups. Those runs for about 12 weeks. So they'll come to this group. The idea in this group is for that they bring a family member so that this is a safe area for the client and the family members who work on their relationships and communication with their sober support with their family member. This is also where we try to help encourage, to the families and the client to learn how to do their communication styles. They learn more about the drug itself. Every week we actually talk about the different substances, how it affects the clients, how it affects the client's brains, how it affects their thought process. This is also a great time to talk bluntly and frankly with their sober support and asking them for guidance and support while they're going through their addiction. Social support, that is, like I said, the aftercare part. That's an ongoing group. We ask that the group members have a minimum of 4 of these sessions just to maintain. We're finding that the majority of the people in social support tend to stay because they start building those bond and that therapeutic relationships with each other and along with the staff. And then we pull from this group for that peer panel because in Lesson 3 of Family Education, it talks about peer panel, and you want the peer panel to come and talk to your clients about their struggles with addiction and their struggles with the different areas. So this is where we pull from that for that peer panel is the social support. I think right now we have a member in there that's been there for about 1.5 years, almost 2 years, and they keep coming because it's a structure. It gives them something to do. We also incorporate individual sessions. So if an individual is really coming in and they're acutely using and they're really struggling with their addiction, we could potentially see them for 4 days because you've got early recovery skills and relapse prevention on Monday, and then like you could do an individual on Tuesday, and then you could have them do family education on Wednesday. Thursday could be that early recovery skills, relapse prevention, and then Friday could be a follow-up with our addictionologists that we have on staff. So we try to make sure that we're seeing these stimulant users at least 1 day, or daily, I should say. And then eventually, once they get stabilized, we find that we can slow down and start eliminating not seeing them every day. But we're finding that the more that we keep them engaged and give them that structure, that they're more likely to be successful. And plus, this seems like this is their safe area, and so they keep coming back. The other idea to see them 5 days a week is to help with recognizing their relapses and to process it as fast as we can so that they're able to understand more about their relapse and the potential of stopping it from continuing again. So that's one of the main reasons, especially early in recovery. The importance of accountability, I put that here because if we have clients that don't show up for group, then we make a phone call. We're calling the clients, we're asking them, hey, where are you at? What stopped you from coming to group? What stopped you from being a part? What happened? So this gives us a chance to talk about, the importance of the scheduling, the importance of structure, keeping your responsibility of attending groups. Part of our policy then is having them come in for a urine drug screen, just so that they can understand that this is treatment and that it's more about, structure. It's more about just being clean. It's about living a recovery life or living in a sober lifestyle. Sometimes these phone calls are also a really good brief intervention is needed. At times it's, hey, this is what happened. Thank you for calling. We're finding out that more individuals are really enjoying the fact that we're calling them and checking in. Individual sessions are 1-hour sessions. Like I said, it's added support. We do urine drug screens. Oops, I went backwards. The facilitators' role in these groups are to keep the group members entertained. Stimulant users really struggle with attention, and so you got to have these topics come alive. You have to these topics, and you have to not entertain them, but interact with them and make sure that they're fun, exciting, and yet they're learning, and you're creating a really safe area for everyone. Those are my references, and thank you.
Thanks so much, Regina, and thanks to everyone for joining us today. We are right on time for wrapping up our presentation. Just want to remind you all that we will be forwarding the questions you've posed in